This video presentation will cover the operative surgical technique for performing a minimally invasive endoscopic posterior cervical foraminotomy. The typical case illustration is presented of a 40-year-old gentleman with a long-standing history of neck pain and right C6 radiculopathy of long-term duration. Conservative measures including selective nerve root block, multiple rounds of medications, and physical therapy only provided temporary relief. An axial and sagittal T2 weighted MRI of the cervical spine, as shown here, demonstrates significant right C5-6 foraminal stenosis. Given the clinical and radiographic findings, along with failure of conservative management, a right C5-6 MIS posterior foraminotomy was pursued. All patients are induced under general anesthesia and placed in the sitting position. We choose this position because there is decreased pooling of blood in the operative field, thereby increasing operative visibility and decreasing operative time. The operating room table is manipulated to place the patient in a semi-sitting position, with the head flexed and the neck straight and perpendicular to the floor. The head is fixed to a Mayfield head holder in front of the patient. Note that the patient's arms are placed at the waist and padded. The X-ray generator is leveled at the patient's neck with the fluoroscopic C-arm located directly below the operating room table. Note that the base of the fluoroscopic machine is placed on the same side of the decompression. During each case, we also use neurophysiologic monitoring, which includes somatosensory evoked potentials, motor evoked potentials, and free-running EMG. In order to proceed with successful dilation at the C5-6 level, an incision is planned using lateral fluoroscopy. A 1 cm longitudinal paramedian incision is marked approximately 1 cm off midline on the operative side. Once the optimal trajectory is established, the patient is draped in a sterile fashion. The skin and fascia are incised sharply to avoid increased downward pressure during dilation. The met scissors are used to bluntly dissect parallel to the muscle fibers to enable a force-free insertion of the dilators. The smallest dilator is initially inserted through the posterior cervical muscles under fluoroscopic guidance in a more lateral to medial trajectory. The ideal docking point is the superior aspect of the lateral mass of interest. We aim for the superior facet because as dilation occurs, the tube will naturally settle caudally, which will be the location of interest under the endoscope. Each tubular dilator is carefully rotated and then gently inserted. Again, it is important to stress that it is done in a force-free manner. Fluoroscopy is again used to confirm the location. As you can see, the tubular dilator has slowly settled caudally. The dilators are connected to a table-mounted retractor arm, generally with the help of an assistant, and secured in place. The tubular dilators are subsequently removed and a final lateral fluoroscopic image is obtained. Finally, the endoscopic camera is inserted and attached to the tubular retractor. The tubular dilator is oriented in such a manner that cranial is at the top of the screen and lateral is to the right of the screen. Dissection begins with the use of monopolar cautery, as shown in this tubular view. You should begin laterally over solid bone and carefully work in a lateral medial direction. The safest place to begin is actually the craniolateral aspect of the tubular dilator, as shown in this view. As dissection moves medially, or toward the left in this tubular view, you can use the bipolar cautery and a pituitary rongeur to remove excess muscle. This also avoids puncturing the dura with a monopolar cautery. Kerrison punch is also used to help remove any of this extra tissue. As you move medially, an up-angled curette and a Kerrison punch can be used to dissect and remove soft tissue from the lateral mass. A bipolar cautery can be used to maintain hemostasis as well as help dissection. Once the medial edge of the facet is identified, an up-angled curette can be used to dissect a ligament from the undersurface of the lamina in order to identify the interlaminar junction as shown here. You may experience some epidural venous bleeding in this area, which can either be controlled with a bipolar cautery or thrombin-soaked gel foam. A high-speed drill or the Kerrison punch can be used to remove the dorsolateral portion of the superior lamina and the medial part of the inferior articular facet. To expose the medial border of the caudal pedicle. which can be palpated with a fine-angled dissector. The nerve root is going to be located directly above the caudal pedicle and anterior to the superior articular facet. In this case, the kerosene punch was easily able to enter the interlaminar space and begin removing bone. However, at some point, a high-speed burr may be needed to thin the superior and inferior articular facet in order for a kerosene punch or an up-angled dissector to remove the bone. Now that the caudal pedicle has been identified, a kerosene rongeur is used to remove bone in the cranial direction to help identify the cranial pedicle. As the nerve root is decompressed, you may encounter an increase in epidural bleeding, which is generally not an issue as it pools at the inferior portion of the tube. Thrombin-soaked gel foam, or a hemostatic agent as shown here, can be used to help with hemostasis. Once hemostasis is achieved, you should be able to appreciate a pulsatile dura. At the completion of bony decompression, a fine-angled dissector is used to palpate the lateral wall of the caudal pedicle as well as the cranial pedicle to ensure that an adequate decompression was achieved. The tubular dilators are slowly withdrawn, and careful hemostasis is performed with bipolar electrocautery of muscle and soft tissue if it is bleeding. The wound is closed using 1 or 2 absorbable sutures in the fascia, 2 or 3 inverted stitches in the subcutaneous layer, and a derma bond for the skin.